Welcome to good afternoon, everyone. Welcome to the second day of Sankalp series of webinar for the medical colleges of Maharashtra. Yesterday we had a very interactive session on few topics on in family planning and contraception. I think all postgraduates benefited from it. To continue the efforts today, we will be having 3 talks. Before handing over to Dr. Viju to conduct the entire session, I request Dr. Lakshmi, the chairperson, to say a few words as a feedback from yesterday's and few encouraging words for today. Over to you, Lakshmi.
Yeah, thank you so much, Dr. Shobha Gudi. Yesterday's program was too good. I could see the interactions going on, the discussions going on, and this program has generated so much interest among the medical colleges and its teachers. I'm really happy and I appreciate your hard work and coordination which you have taken for this program. And we will take it further with a bit of modification. And I welcome all the postgraduate students, medical teachers who have logged in. Just one word as ICOG chair that please log into our ICOG website, icogonline.org. You all are most welcome to become our fellows. And there is a conference, that is FOGSI ICOG National Conference on 4th and 5th March at Nagpur. So encourage your postgraduates to present paper as this is a national conference. So certainly there will be ICOG points and MMC credit points will be there. And after finishing your post-graduation, postgraduates can join our 6-month courses. We conduct these courses in 6 specialties, that is reproductive medicine, endoscopy, ultrasound, fetal medicine, vaginal surgery, and critical care. So I would just urge once again to all of you to go and visit our website for further details. And apart from this Sankalp webinar, we are having a series of webinars. Every webinar is free of cost. Just go to our website and we have posted our December and January calendar. So go through it and do join to our other webinars as well. Now, without wasting much time, I hand over back to Dr. Shobha for further proceedings.
Riju, please take over.
Thank you so much, Dr. Lakshmi Shikande, ma'am. So without further delay, I would like to invite our first speaker, guest speaker, Dr. Pratik Tambre, sir. Can I have the CV of Pratik, sir, please? So sir is Governing Council member, ICOG. He is a senior ART consultant and gynae endoscopic surgeon and trained in ART as well as clinical embryology. He is the chair amongst Endocrinology Committee 2020-24. He is also Governing Council member of ICOG 2021-23 and patron MCM Mumbai OBGYN Society. He is recipient of several MOGS, AMOGS, FOGSI awards and contributed over 75 chapters, invited for more than 1,000 faculty, invited as faculty for more than 1,000 events and CMEs. Welcome, sir.
Good afternoon, everyone. Let me begin by expressing my gratitude to Dr. Lakshmi Shikande, who's our chairperson of ICOG, and Dr. Shobha Gudi, whose brainchild this entire Sankalp series is. Dr. Shobha Gudi, for those of you who are unaware, is actually the immediate past chairperson now of the Family Welfare Committee. She has been closely working not only with the government in Karnataka, but also the central government in Delhi on various issues related to family welfare, contraception, and family planning. I remember that she had a fantastic tenure. She was also the organizing chair for AICUG 2019, which was held in Bengaluru, and which was a very tough and difficult task. It happened just immediately prior to the pandemic, and I remember it was a fantastic congress with, I think, about 8,000 to 10,000 delegates that they had welcomed. So hats off to you, Dr. Shobha, for doing fantastic work throughout your tenure, not just as the president of the Bengaluru Society, but also in FOGSI as the Family Welfare Committee chair. I'm here to speak about hormonal contraceptive methods. And since this is a standard set program with a standard set of slides, I have not modified any of the slides. In fact, I would like to acknowledge the contribution of Dr. Archana Mishra, who's an associate professor in OBGYN at the VMMC and Safdarjung Hospital in New Delhi. She's the person who has contributed the set of slides which you am about to deliver today. So when we talk about hormonal contraception, there are various different routes of administration, and there is a wide variety of formulations which are available in the market. And I remember 30 years back when I was studying medicine that there was a standard word which was used whenever we talked about planning contraception or family welfare, and that is cafeteria approach. And nowhere else is it more highlighted than in this particular case where we talk about hormonal methods of contraception. So hormonal methods can be delivered orally, injectable form, as implants and as IUCDs. As we know that these are in existence since at least 40 to 50 years, probably even longer. And over a period of time, these have been refined and we have tried to minimize the side effects with these formulations, try to combine them in different strengths and proportions, which we will be covering shortly. Traditionally, we always have one estrogen and one progesterone. These give us what we call the combined oral contraceptives. You can also deliver them now, more recently, in transdermal fashion, as well as in the vaginal ring form. For certain particular high risk groups of patients where we don't want estrogen to be used, we can also have progesterone only pills, and that we will see in the later part of today's talk. So what are the benefits with combined hormonal contraception or the traditional pills, which we call the pill? Whenever we talk about the pill, we are referring to the older second generation COCs. But in general, when we talk about COCs, we know that they are effective, they have a very good Pearl index, they can be used in a wide variety of patients, they are rapidly reversible, which means that return to fertility is almost immediate. The very next month after the patient discontinues, she can get pregnant if she so wishes. And the failure rate is quite low. If you contrast this with the traditional condom which is available for the male partner, the failure rate in condoms can be anywhere between 5 to 15%. Whereas in COCs, if it is taken properly, it is as low as 0.3%. Of course, in the initial year of use, it may be slightly higher until the patient is little comfortable and has got disciplined into taking it at the same time every day. So broadly, we classify these on the basis of the estrogen content. As I said, when they first came out 40, 50 years back, the initial generations had high doses of both estrogen as well as progesterone. Now, what is available in the current scenario is low dose pills, where ethinyl estradiol is typically available in 30 to 35 micrograms. You also have the very low dose estrogen pills, where ethinyl estradiol is of a very small magnitude, 15 to 25 micrograms, typically 20 micrograms. You can see the brand names mentioned there, and many of these will ring a bell because they prescribe these left, right, and center, day in and day out in clinical practice. There is also an alternative to ethinyl estradiol, which is the traditional form of estrogen, which was available for several decades, and that's the estradiol valerate. And some new pills also incorporate this to obviate the side effects of ethinyl estradiol. Traditionally, they have been divided on the generations depending on what is the progesterone, and you can see the various different formulations of progesterone mentioned there. But the newer formulations is what we will try and focus in today's talk. And these are the ones which have made life so much easier for the modern women, namely drospirenone, cyproterone acetate, gestodine, and desogestrel. So COCs typically are 21 plus 7, where 21 pills are hormonal pills and 7 pills are non-hormonal or iron dummy pills, so to speak. And you can see the pictures there of Mala N, which is available freely at all primary health centers. This is also available in the interiors through ASHA workers, and this is a free supply without any financial remuneration which is required. Coming to the pharmacological characteristics of the various different progesterone compounds which are present in these pills. The older brands used to have a high amount of 19 nortestosterone activity, which means that they were strongly androgenic. They used to cause water retention, there used to be weight gain, and those are all the older generation pills which we used to prescribe maybe in the 70s and 80s. If you contrast this with the newer generation starting from desogestrel, cyproterone, drospirenone, and dinogest, you'll find that they do not have much androgenic activity. In fact, some of them even have anti-androgen properties, which they are famous for. And a lot of these pills, when they first came out, namely cyproterone and drospirenone, were actually marketed as weight loss pills because they were anti-androgenic in their function. They also gave a very excellent contraceptive efficacy, and that's why these pills have become very popular amongst the intended population in the past couple of decades. How do they act? I think it's something which we've all learned in MBBS days. So I don't want to bore this audience by telling you that it blocks the LH surge, it blocks ovulation. There are multiple mechanisms as well. In addition, in case there is an escape ovulation, there is thickening of the cervical mucus, there is change in the peristalsis of the fallopian tubes as well. And most importantly, the endometrium itself becomes non-receptive to embryo implantation. Therefore, there are various different safety mechanisms which are built in into combined oral contraceptives besides the usual standard blocking of ovulation. How do we prescribe these? As we said, it's 21/7, which has been the traditional way of prescribing or administering. You now have a newer alternative, which is 24/4, 4 days of pill-free interval and 24 days on. The advantage with this newer 24/4 regimen is that there is a shorter pill-free interval, cycle control is much better, and you have better control of the ovarian suppression. Also, the modern pills have little lower content of estrogen. Therefore, sometimes a 24/4 regimen is preferred in modern practice. There are also other alternative regimens which you will see mentioned here on the slide. This is just to complete the entire slide and the knowledge that you need to have. But in practice, most of us don't prescribe these. 84/7 and 42/7 are not commonly prescribed in clinical practice. The monophasic pill, as you can see, typically has low dose of estrogen. 30 to 35 micrograms is the older generation. The newer generations are 15 to 25 micrograms. And the multiphasic pill is not so commonly prescribed. In fact, it's not even available in India. Triphasic pills are available in India, and this was a very popular question during my undergraduate and postgraduate years for short notes, etc. And I'm pretty sure it's still popular even now in medical exams. The advantage with the triphasic pill is that the hormonal content is much lower in the first and the second phase. In the third phase, when you need to have good cycle control, that's when the levonorgestrel content is raised, and this gives you excellent cycle control. There are lesser side effects because the first two phases, the amount of progesterone is lower. Therefore, you have less breakthrough bleeding and lesser failure rates. Unfortunately, sometimes what happens is patients fail to follow the color coding. They may not take it in the correct sequence. Even though there are arrows at the back, there may be miss pills or there may be mistakes in taking the pill, and that leads to a higher failure. When it comes to prescription of combined oral contraceptives, we've all been taught traditionally that there are certain things that we always need to rule out before we prescribe a COC to a patient. So detailed history, clinical examination, rule out a family history, look at the blood pressure, very important, and you need to rule out the contraindication. What are these contraindications? Typically, you always obviously have to rule out pregnancy. We need to ensure that the patient is not breastfeeding. If she is breastfeeding, then she falls into a particular category. That slide is just coming up in the next 10 seconds. Obviously, in India, cigarette smoking is not so much of an issue, but epilepsy and migraine is something which we need to inquire into. Family history and a past history of diabetes and hypertension is extremely important. History of DVT, liver and liver disease and jaundice, and of course, if there has been any history of malignancy in the past. So this is the standard WHO medical eligibility criteria. This is available on the WHO website as well, and it classifies patients into 4 different categories. That is MEC 1, 2, 3, and 4. I will not extensively read out all of them because this is well known. In fact, WHO has a wheel which helps you to make the choice of which particular contraceptive can be prescribed to patients. MEC1 typically can be used for any woman from menarche, 40 years of age, more than 6 weeks postpartum, non-lactating. She may have varicose veins, a past ectopic pregnancy. All these women will fall into MEC1. MEC2 are women who are breastfeeding less than 6 months, 3 to 6 weeks postpartum, and women who are more than 40 years of age. MEC3 is where there is a much higher risk in these patients. If they are less than 3 weeks postpartum, non-lactating, if the age is more than 35, if they are smokers, if they are hypertensive, then all these women will fall into MEC3. And obviously here we have to be very careful when we are prescribing any hormonal pill to these women. In contrast, MEC4 is the highest risk, where you have multiple risk factors for cardiovascular disease, hypertension, venous thromboembolism, non-ischemic heart disease, history of stroke. Typically, these are the women where you don't want to use hormonal contraception and where you would want to offer something like a barrier. So how do we start a hormonal contraceptive? Traditionally, we have always been taught that you start from the 5th day and continue till the 25th. The modern thinking is the day the woman comes, please start. Don't miss the opportunity. Don't wait for her to get her period and then start on the 3rd, 4th, 5th day, etc., etc. Start the moment the patient comes. Do not miss the opportunity. You have to remind the patient that menses may be delayed or irregular. If she is regularly ovulating, she comes to you, then that's absolutely fine. In Western countries, there is a concept called as Sunday start, where they always start a new pack of pills on a Sunday. And depending on when you are starting, then you may need a backup method such as barrier contraceptions for up to 7 days. If the patient has just recently had a miscarriage or a termination of pregnancy, you can start within 7 days. If she has undergone medical abortion, then you can do it immediately when you give the misoprostol tablets, or you can start within 5 days of the completion of the MTP. Emergency contraception obviously is a different ballgame altogether, and we'll address that a little later. Common question which patients have is, doctor, what do I do if I miss a pill? And sometimes you will get frantic phone calls that, doctor, I have missed 2 pills, now what do I do? So the traditional teaching always has been that if you miss 1 pill, then take the next pill as soon as you remember. If you miss 2 pills, then you need to have a backup method. 3 or more pills, typically you need to have a backup method such as a barrier contraception, which is to be used. If you miss in the 3rd week, then you can start the next pack immediately. That's the recommendation. If you miss in the 1st week, then obviously that is going to impact the fertile period, and therefore you need to have emergency contraception as well, which is administered. There are a number of benefits with hormonal contraception, which are non-contraceptive benefits as well. And the newer pills which are available have been the ones which we prescribe for these non-contraceptive benefits. Patients with PCOS, hyperandrogenemia, obese women, patients who have dysmenorrhea, who have menorrhagia, Mittelschmerz, ovarian cysts, all these patients will find significant improvement once you prescribe combined oral contraceptives, and they are taken sincerely and properly for a substantial length of time. You also find that patients who are on COCs will have a lesser risk of PID, especially if they follow the belt and suspender approach, as it's popularly known. Also, a lesser incidence of anemia because 24/4 regimen means that there is a lesser pill-free interval and therefore lesser bleeding. Much lower risk of uterine and ovarian cancer and decreased risk for benign breast conditions. There are other postulated benefits as well, but these are something which we will need for the textbooks. They may not be of much practical importance. The most common side effects which we get are because of the hormonal content, and nausea, vomiting, and difficulty in keeping food down is something which commonly happens in the first couple of months. Breakthrough bleeding may also happen, especially with the newer generation low dose pills. This usually resolves in 3 months. You can have oligoamenorrhea or irregular bleeding, which happens in the first few months. Usually, this will settle over time. Cloasma and weight gain are more common with the older generation, which had high estrogen content. With the modern low dose pills, you don't commonly get that. There are some issues which we need to be aware of, and this should form part of the standard counseling whenever we are prescribing of hormonal contraceptives to a woman. This includes the possibility, a remote, however it may be, that the incidence of stroke, venous thromboembolism may increase, and extremely rarely myocardial infarction. Now, obviously, that is why we need to have those MEC classification, and you need to put down the patient into those 4 different groups and then appropriately prescribe her the correct hormonal contraception, which is appropriate for her. There are some drug interactions. We are aware of these since our second MBBS pharmacology days. So I'm not going to sit and read out this slide, but there are some drugs which interact with hormonal contraceptives, hepatic enzyme inducers very commonly, and rarely also vitamin C. So these are the different types of newer pills, which I think we should be focused more on in my talk, because everything that I've said so far is just a repetition of what you've been taught for donkey's years. Now, the mini pill is something which contains a very small content of pure progesterone. There is no estrogen in this pill. The advantage of this is that it can be prescribed even to lactating women. And this is a very important time because even in the lactation period, women are not protected. There can be an escape ovulation and pregnancy can result. And therefore, in that period, you need to put your patients on something which is safe as well as effective and will not affect the milk secretion, which is important in that particular period. So obviously they inhibit ovulation, cause involution of the endometrium. You can see the different trade names mentioned here. We don't specifically endorse any particular brand, but those names are important because they tell you which particular drug is actually the active ingredient in that particular formulation. So how do you prescribe these? The prescription typically is whenever the patient comes to you, you can start. If she comes to you within 6 weeks of delivery, ideally at the first PNC follow-up, you can start it immediately and no backup method is required. If she has had a period, then you can start it immediately. If she comes to you more than 7 days later, then a backup method may be required. Especially in women who have diabetes, cardiovascular issues, SLE, where you can't prescribe estrogen, this may be the only pill which you can prescribe to these patients. And they are excellent, especially the modern formulations, because patient acceptability is good, full index is quite low, and in lactating women, probably besides the IUCD, this is the only drug that you can prescribe. Injectable contraception is something which has been widely available throughout the world since at least 30-40 years. Unfortunately, in India, it's not always taken up very well because in India, the issue is that women want to ensure that there is no intermenstrual bleeding. The advantage with injectable contraception is that you just need to take one shot. every 3 months, and you're completely protected. You have flexibility that within plus or minus 2 weeks, you can take the next shot at any time of your choice. The problem is that you can have intermenstrual bleeding, and sometimes because of religious reasons, this is not commonly accepted in Indian patients. Women who are obese, who have seizure disorder, sickle cell disease, sometimes in very specific conditions, women who are athletes or who are in the armed forces, these patients, you can use these with great efficacy. The contraindications obviously are anything related to hepatic issues or unexplained vaginal bleeding. You usually give this as a single shot. It can be given subcutaneously or intramuscularly. Typically, intramuscularly is what we prescribe, and it has to be given by the Z technique. The recommendation is that you don't massage after you give the injection. All the advantages are obviously very clear, that it's one single shot, does not interfere with the act of coitus, and it's very suitable for lactating women. Again, if you can think of the mini pill, all the advantages of the mini pill also apply because it's the same progesterone content which is being used. The disadvantage, as we said, is that there may be some amount of weight gain. There can be changes in the menstruation pattern, and this may not be acceptable to women. There is a very small, statistically insignificant risk of increase in breast carcinoma, which has been seen, but that's something, as I said, again, it's not statistically significant. Transdermal delivery systems are available in Western countries. I'm not sure if they are widely available in India. This includes patches, gels, and sprays. And the advantage of these is that they have very good patient acceptability. Unfortunately, I don't think these are widely available in India. One patch will last you for about a week. What is widely available in our country is the vaginal ring, and the trade name Nuva ring is well known to all of us. It's excellent as far as contraceptive efficacy is concerned. You need to change it every 21 days. You have a 7-day interval where you don't wear the ring, and that's when you get the withdrawal bleed. You can change to a fresh ring once every 3 months. The advantage with this is that the patient can do it on her own. She doesn't need to keep visiting you except for the first couple of times until she is comfortable. Does not interfere with the act of intercourse in any way, and it's something which many women have taken up in a big way in our country. Implants are something which we always used to have a short note about, and at that time, I think Norplant and Implanon were the two which were very widely available. There are others also now. These are active up to 3 years, and the advantage of these is that it's a single procedure, and these rods which are available are something which most patients, once they have used them, are quite comfortable with. Again, the same disadvantages apply, that there can be breakthrough bleeding. Patients may be a little uncomfortable with that initially. Emergency contraception is something which is a whole different ball game, and all of you are aware regarding the finer points. The standard regimen which we were taught 30 years back was the USP regimen. That's the second generation COC overall. You can take 4 tablets, 2 tablets, 12 hours or 24 hours apart, up to 72 hours of unprotected intercourse. Postcoital IUCD sounds very good in theory. You can use it up to 5 days, but that may not always be applicable in all patients, especially nulliparas. Ulipristal is something which is very widely available, and mifepristone, of course, is quite commonly prescribed. Both of these are the newer and modern methods of emergency contraception. LNG IUS, one last slide before I wind up. I think I have exceeded my time, so I should stop here. LNG IUS is an excellent system, especially in women who have endometriosis, heavy menstrual bleeding, and who have had one child earlier. They want to use a spacing method. One single shot can protect you for up to 5 years, and the failure rates are quite low. So to conclude, ladies and gentlemen, think this was a very quick overview of all different types of hormonal contraception and excellent set of slides contributed by Dr. Archana Mishra. My gratitude to Dr. Shobha Gudi for putting together this entire Sankalp program. Thank you very much for inviting me to be here. Please remember the WHO MEC wheel. Make sure that your checklists are always followed. Document everything very clearly, and a good counseling session at the beginning is all that is required to ensure that there is good contraceptive efficacy and a low failure rate with hormonal contraception. Thank you again, Dr. Lakshmi and Dr. Shobha, for inviting me to speak.
Thank you so much, sir. So we have a couple of questions. So can we take it now or?
Yeah, sure. Unless we are holding up any of the other speakers.
No, I think you take it now, Riju.
Okay, ma'am. So,
and I must thank, 1 minute, let me just thank Pratik for the excellent deliberation. I think, I knew that I am having the right faculty for this topic because as chairperson endocrinology committee, he did such fantastic work. And I used to call him am I audible, Riju?
Yes,
ma'am, we can hear you.
Yeah, I used to call him the pituitary gland because he's the master endocrine gland. So I used to call him that. It's such wonderful work he did. So now I think we must reap the benefits of his work. Thank you very much, Pratik, for giving your time today.
Thank you.
Thanks a
Thank
lot.
you, sir.
Thanks a lot.
Yes. So we have a question from Dr. Varsha Sinha. How much time does irregular menses last after DMPA injections?
So this has traditionally been one of the criticisms of all injectable contraceptives which are long acting, not just the DMPA but also the NET-M, that the return to fertility can be quite delayed. And consequently, your return to a normal menstrual pattern can also be delayed in these women. In some women, typically within 3 months after the last DMPA or NET-M, your menses will resume. But there have been reports of women taking as long as 6 months to 9 months before the next menses and the ovulation has resumed. So if you have a woman who wants quick return to fertility, then probably DMP and NET-M is not the way to. It's very convenient because you need to take a shot just once in 3 months. But in practice, if she is disturbed by breakthrough bleeding and she wants a quick return to fertility, this may not be the perfect choice.
And so how to induce withdrawal bleeding in amenorrhea due to DMP injections? Do they need both E plus P?
So what happens is, since already there is an abundance of progesterone in the system, which is being released intramuscularly from a depot format, the traditional progesterone challenge test is not going to work in these patients. There's already lots of progesterone. So you're going to need at least 10 to 15 days of estrogen. Obviously, you need to confirm that the patient is not pregnant before giving her estrogen. Make sure that the UPT is negative. Then give her at least 10 to 15 days of estrogen followed by a progesterone challenge. E plus P will be required, but not the standard 5 days of estrogen. You're going to need at least 10 to 15 days of estrogen.
So what precaution is to be taken while giving OC pills to hypothyroid patients?
There is no interaction as far as your levothyroxine and OC pills are concerned. The only interactions that are noted are with hepatic microsomal enzyme inducers. All that you need to be aware is that patients who have hypothyroidism, if they are well controlled and their TSH is within range, just need to monitor them once in 3 months, and giving them OC pills is absolutely fine. Should not be.
I think that's all, sir. Thank you so much for your excellent deliberation and for your time and expertise.
Thank you, Dr. Raju, and thank you, Dr. Lakshmi and Shobha.
Thank you. So moving on to our next speaker, I would like to invite our next speaker, Dr. P. Padmaja. Can I have a CV, please? She'll be talking about natural and barrel contraceptive. Dr. P. Padmaja is the senior consultant and HOD at Government Hospital, Doda, Ballapur. She is a postgraduate teacher and examiner. Can I have a CV, please? She has received Distinguished NBE Teacher Award by ANBI in 2019. She is a chairperson Poster Committee AICOG 2019, member BSOGS CME committee and faculty at many national and international conferences. Welcome, Dr. Padmaja. Dr. Padmaja.
Dr. Shobha, I think Dr. Padmaja is
Not
not.
logged in. Yes, yes, ma'am.
Just find out now, call her and then find out.
Sure, ma'am. Dr. Malini, ma'am, meanwhile, can we move on to your, is it okay if we move on to your turn?
Sure.
Okay.
Shall I share my screen?
Sure, ma'am. So, moving on to our next topic on sterilization, I would like to invite, can I have Malini ma'am CV, please? I would like to invite Dr. KV Malini ma'am. She is a professor HOD at OBGY department of Sri Atal Bihari Vajpayee Medical College and Research Institute, Bangalore. And she's been an examiner for 26 years, NBE teacher and inspector. And she is a master trainer for training programs like RCH, PPTCT, EMOC, PPIUCD, and CSE. And she has innumerable awards and publications in her bag. Welcome, ma'am.
1 minute. I'll
Yes.
1 minute. I have a problem sharing my screen. Just a minute, I'll call.
You open the PPT, no, Malini?
Okay, I should minimize this. Should I?
Open the PPT and minimize the PPT on the screen itself, and then go to the login section.
Wait.
No.
1 minute. I got
Minimize the PPT, yeah, and then screen share from our open window, from our this thing, webinar ka screen, no?
I have opened it. Okay, I'll just
Minimize
share
it on the
screen.
screen. Yeah, share screen.
Yeah. Yeah. Can you see?
Not yet.
Can you see? I have shared.
No, ma'am.
I can see it now. I don't know. Just a minute.
Yes, ma'am. It has started.
It has started now.
Yes, ma'am.
1 minute.
Please go to slideshow now.
Yeah. I'll go to slideshow. Yeah, can you see now? Yeah. Yes. Shobha?
Yes,
Can you
ma'am.
see?
Yes,
Yeah.
ma'am.
Okay. So at the outset, I would like to thank ICOG Chairperson Lakshmi Shrikande and
Yes,
of course our
very
own.
much. Please go ahead.
Yeah. Shobha Goody for giving me this opportunity to interact with the postgraduate students because teaching is my passion. Okay. I'm going to speak on sterilization operation. I don't know like how much all the postgraduates know about sterilization. So this is just, to say that population naturally increases the poverty and decreases the prosperity, and contraception is the only way to control population. And I just want to mention about these classification of contraceptives. We have spacing methods. See, earlier we used to call it as temporary methods and permanent methods. Now it is renamed as spacing methods and limiting methods. Spacing methods can be used for a certain period of time and can be stopped whenever the couple wants to conceive. And limiting methods are decided by the couple after completion of the family, and these are almost irreversible. And these are some of the limiting methods that we have. For male, we have the traditional vasectomy, and the no scalpel vasectomy. And for female, we have abdominal mini lap tubectomy, which is widely used. And nowadays, of course, the laparoscopic tubal occlusion. And there are other methods like hysteroscopic sterilization, vaginal tubectomy. Whenever you are doing surgeries like further gills, you can combine that with the vaginal tubectomy, and cholecystoscopic, which is almost obsolete now, of course. Now, before going further into the presentation, I just want to present this case. This is for the postgraduates. Just you don't have to answer right now. 31 years, primary gravida with term pregnancy and no medical problems. Is planned for cesarean operation, indication being cephalopelvic disproportion. She requests the doctor to perform sterilization operation as she is not interested in second child and does not want to undergo another operation, because this is the usual scenario. And because nowadays all these working women, they conceive late and they'll undergo cesarean and they don't want to come again. They'll insist on sterilization operation along with cesarean operation. As a doctor, what will be your answer? Don't answer right now. I'll ask you later on, okay? Now, coming to female sterilization, a little bit about history. It was in 1823, James Blundell suggested about sterilization with cesarean, but it was Samuel Lundgren who performed the tubectomy first in 1881 while doing cesarean. We don't see these people's name actually, but in 1910 in Germany, Madlener described his procedure, and we know Madlener's procedure and Pomeroy's method, which was introduced in 1990 in New York, and Irving from Harvard School, he introduced his method in 1924, and Uchida reported his method in 1946, and we know all these people, right? And 1970, laparoscopic methods made their entry. Now, what is the rationale behind the sterilization operation? So it's something like, the fallopian tubes are either ligated, cut and or blocked with fallopian rings, I'm sorry. So this creates a block for the sperm and ovum to meet each other, and sterilization is not possible. It's something like, the Romeo sperms are, desperately searching for the ovum, which is sadly sitting on the other side of the wall, waiting for the sperms to come, but it cannot reach, okay? At the same time, reversal too is not very easy. This should be remembered, because the women, many a time women think that reversal is easy and they come for reversal of sterilization. So while counseling for the surgery for female sterilization, it should be projected as an irreversible procedure. Now, this is the latest survey, the DLS survey 5, which is conducted in 2019-21. It is heartening to note that in almost 67% of the women are using one or the other method. And of all the methods, female sterilization again is dominating. 38% go for female sterilization, and spacing methods are not so, popular. And it's sad to know that the male sterilization from the previous survey 0.6, it has come down to 0.3%. It's not very popular. So this is again progress under family planning program as per health management information system. So we can see that out of all the sterilization operation, it is the female sterilization which is dominating. It's good to know that the IUCD is gaining popularity, especially the PP IUCD. And this is the state-wise and union territory-wise contraceptive use in our country. I being from Karnataka, I'm happy that we are, like almost in par with our neighboring states, Tamil Nadu and Telangana. Surprisingly, Kerala is just 61%. It's really surprising. And Delhi and West Bengal, these are at the top, actually speaking. Chandigarh is at almost top. Okay. So when do we do this sterilization? What is the timing? So it can be done concurrently during cesarean operation or during hysterectomy as a method of medical termination pregnancy. And postpartum sterilization, as all of you know, can be done after 24 hours and within 7 days of childbirth. Mini-lap tubectomy is the method of choice when we are doing postpartum. Laparoscopy is not usually advocated, though we were doing laparoscopic tubal occlusion earlier. This is not recommended now by the government. Interval sterilization is ideally done after 6 weeks of childbirth. Pregnancy should have been ruled out if menstruating, preferably done during the first 7 to 10 days of the cycle for obvious reasons. If inevitable, then rule out pregnancy and then perform sterilization. Both mini-lap and laparoscopic methods can be used. And post-abortion sterilization, it can be done immediately following an abortion or MTP after injection, after infection is ruled out, or within the first 7 days, after MMA, after her next menstrual cycle. And if it is second trimester termination, mini-lap is preferred. LTO is not recommended. Suppose she is using any other contraceptive, then like IUCD, for example, IUCD can be removed and tubectomy can be done concurrently. If on OCP, it can be done anytime, but she is asked to continue the pill till she finishes that packet and to maintain the regularity of her cycle. And after emergency pill within 7 days of next cycle. Now, how do we select the cases? This is the NHM guideline. Self-declaration by the client will be the basis for compiling this information. Now, it's said that whenever a woman comes and approaches you for a sterilization operation, she should not be denied. The medical eligibility criteria for female sterilization operation in general is totally different. And it is different. Sorry, some disturbance, Shobha. So
I request all the participants to kindly mute themselves.
For the other contraceptives, you have category 1 to 4, but here you have a different medical eligibility criteria, which I'm going to mention now. And client should be married, including ever married. That means widow, if she approaches for sterilization operation, that it's not recommended. Female client should be above the age of 22 years and below the age of 49 years. And I think these will be viva questions for the postgraduate students, you know.
Ready, Anna?
Selection criteria for women for sterilization operation. The couple should have at least one child whose age is above 1 year unless the sterilization is medically indicated. Clients or their spouses or partners must not have undergone sterilization in the past. It's not applicable to failure of previous sterilization. Clients must be in a sound state of mind so as to understand the full implication of sterilization. Mentally ill clients must be certified by a psychiatrist, and a statement should be given by the legal guardian or spouse regarding the soundness of the client's state of mind. Now, clients have made an informed decision for sterilization voluntarily. No one should be coerced for sterilization operation. So this is the eligibility of the client as per medical eligibility criteria. No medical condition should prevent female sterilization. It is just accept when there are no contraindication, or take caution, that is extra preparation and precaution is needed, and delay, postpone the procedure, evaluate, treat and resolve the situation, use spacing methods for some time and then perform sterilization. And there are special groups which need expert surgeons, anesthetists and equipment. In this particular group, maybe like other methods could be preferred, but if the woman insists on sterilization operation, then you have to treat her as a special group and take expert opinion from other team. So this is a big list of conditions where you should be cautious. Now, I would suggest that you make a list and then just paste it on your in your ward or near the OT, so that you'll take a decision as to what to be done. Okay. So delay or postpone, especially say if she is severely anemic, means definitely you'll correct anemia and control diabetes mellitus. If she's pregnant, means like maybe you'll have to postpone naturally, current DVT and things like that. Okay. So there's a big list. And special cases are like those where fixed uterus due to past surgery, where you may have to call for the general surgeon, or postpartum ruptured uterus, perforation, and diabetes mellitus with more than 20 years with the organ damage, maybe a multidisciplinary team is needed. And there is another big list of conditions like that. Okay, so you have to have this checklist. So in comprehensively, if I say accept when there is no medical reason to deny the method, caution procedure to be done with extra precaution, for example, say obesity, controlled blood pressure, epilepsy, hyperthyroid, kidney disease, etc. Then delay, evaluate and treat the patient if she is having current DVT, pneumonia, PID, severe anemia, or diabetes. Then special procedure to be done in setting with the experienced surgeon, equipment to provide general anesthesia, backup medical support, for example, uncontrolled blood pressure, coagulation disorder, uterine rupture, etc. Then how do we evaluate the patient? First of all, you must take the demographic details, her address, name, age, her husband's this thing, everything. And then detailed history, past history, obstetric history, menstrual history is very important as per last menstrual period to rule out pregnancy, then family history, any treatment history, surgical, medical, etc. And do a thorough general examination from head to toe, and then systemic examination. After that, per abdomen, per speculum, and bimanual examination. Though a woman has been evaluated by another obstetrician and then sent to you for sterilization operation, you have to do your own bimanual pelvic examination. And all the above aspects aim to rule out the situation which may warrant postponement or referral of the case, but simply follow the checklist. So you have to categorize them depending upon the situation that you face. Now, this is the consent form, which is very, very important. Before any sterilization operation, you have to take a written consent, informed written consent. So information would be like for any other surgery, the risk regarding the thing and the failure rate and things like that. What I want to highlight is, suppose a woman misses her period, she should report to the facility within 2 weeks, and she can have the medical termination at free of cost. It applies to the private institute, not for the public sector. And one more thing is, suppose, in case of complication, failures of and the unlikely event of death attributed to sterilization, they should accept that the compensation as per the existing provisions of the Government of India, that is Family Planning Indemnity Scheme, as full and final settlement, and will not be entitled to claim any other compensation, including compensation for upbringing of the child, if any born on account of failure of sterilization, over and above the one offered from any court of law in this regard. So this is the Government of India guidelines. So one should know about it, because we have seen many litigation cases where they claim from the operating surgeon 5 lakhs, 10 lakhs and things like that, which is not correct. And in case of vasectomy, they should also know that, up to 3 months, they have to use some additional method. Only when a surgeon certifies that there is azoospermia, they can resume sexual activity. So investigations, now pregnancy test is not usually necessary unless in, say, some exceptional cases where it is difficult to confirm or rule out pregnancy by pelvic examination. They just recommend hemoglobin, and the hemoglobin should be above 7 grams in routine urine examination. This is for IV sedation and local anesthesia. Okay. Extensive laboratory investigations are necessary for procedures under local anesthesia. And if it is under general anesthesia, then maybe you have to have other investigations as indicated. Now here I would like to comment that this, like as per Government of India guidelines, hemoglobin more than 7 grams is sufficient, but no anesthetist will agree for that, I'm sure. So at least 9 grams should be there. And anesthesia, it can be done under any anesthesia, sedation, local anesthesia, regional, general. And if it is sedation, earlier we used to use pethidine with the promethazine, very, very good combination. So the drug is used as per the body weight of the patient. So now we are using pentoxazine because pethidine is not available. Pentoxazine 0.5 milligram per kg body weight and promethazine 0.3 to 0.5 milligram per kg body weight. So if she is thin lady, say less than 40 kg, pentoxazine 15 milligram, and promethazine 12.5 milligrams given 30 to 45 minutes prior to surgery. And an additional injection of pentazocine 15 milligram can be given on the table just 5 minutes prior to surgery. And then if she is between 40 to 55, you increase the dose of pentazocine to 22.5 milligram, and other things are same. And if she is more than 50 kg, then you have to increase the pentazocine to 30 milligram, promethazine to 25 milligram. OT preparation is what should be there in the operation theater, apart from the equipments, a scrub nurse and an OT attendant who will provide support to the client should be available. The operating table should be cleansed with the disinfectant like 0.5% chlorine solution. Suppose you have operated on an infected case, then disinfect the table after each case, and of course once weekly. And after surgery, all the soil instruments are processed by decontamination in 0.5% chlorine solution, washed and sterilized or subjected for HLD. So that coming to mini-lap tubectomy, the patient preparation, pre-operative preparation nil per oral for 6 hours for solid and liquid for 4 hours. Pre-medication if needed, and IM and IV sedation, skin preparation with povidone iodine, 10 ml of 1% xalokin locally. Incision depending upon the type of sterilization operation, interval or peripheral. So it would be either suprapubic or below the fundus. And identification, once you open the abdomen, identify the tubes and secure the tubes, perform tubectomy as per your institution protocol. We all do modified Pomeroy's technique for interval, and with cesarean, we usually use the Parkland procedure. Post-operative care, check and record vitals every 15 minutes until patient is stable, especially in the first 1 to 2 hours, and complete the client record forms and review upon transfer. Discharge when the patient is stable and ambulant. So these are some of the various methods. The Madlener technique, which is not done nowadays, of course. Madlener is just taking a loop and then you're ligating it. And Pomeroy's, if you cut it, it becomes Pomeroy's technique. And this Irving, of course, it is no doubt it is the failure rate is almost 0%, but it is an extensive procedure where medial end is buried into the myometrium. Fimbriectomy is again 0% failure rate, but not practiced so much. And Parkland procedure where both the tubes are ligated separately and a portion of the tube is cut and removed. Now here the advantage is the whole circumference of the fallopian tube is included. And that's why it is recommended during, concurrently with the, when we are doing, say, along with cesarean operation where failure rate is little higher. Chlorka 6-9 method is also almost 0% failure rate and a little bit longer time it takes. And Uchida technique again, perfect sterilization operation. Only thing is in this particular case, 4 to 5 centimeters of the proximal limb is stripped off from the mesosalp ring. So if she comes for tuboplasty, maybe the success rate may not be so good. Okay. So that is removed and the medial end is buried within the broad ligament in Uchida technique. I'm not going for the video because because of the paucity of time. I'm sure everybody is well versed with this. These sterilization techniques. Then laparoscopic tubal occlusion. One should remember that the Trendelenburg position should not be more than 15 degrees for to avoid any complication. Anesthesia could be anything, local, regional, or general. Incision, depending upon the instrument that you have, it could be double puncture or single puncture. We usually go for double puncture. Instruments, you should not use electrocautery. So usually Fallop rings are used. We are not using Filshie clips. Pneumoperitoneum should not be more than 2 liters. Tubal occlusion with bands are done once the tubes are identified, and inspect other organs. And then you undo the peritoneum and then remove the instrument so that patient will be comfortable in the post-operative period. So this is the 7 mm scope and the ring applicator here. So it's about 2 to 3 centimeters from the cornel, and you are taking the loop of the tube and you are applying the rings, Fallop rings. This is the Fallop ring loader and 7 mm trocar with cannula and ring applicator. Now coming back to this question, sterilization with cesarean operation, the case scenario which I presented, what would be your answer? Anybody? Yes? Nobody is answering. Okay.
We will
Yeah,
we will
answer
follow
is-
NHM guidelines, doctor,
Yeah. Yeah.
because the age of the child should be above 1 year before
Yes.
the sterilization
Yes.
operation is
That's it.
performed.
Yeah. So
And
if
the
say
gest
that,
person is spacing method.
yes, yes, yeah. So you are very right. So the answer should be no. You have to counsel her properly. Okay, as per government of India guidelines, you cannot perform sterilization operation with the first cesarean. Now, this is a certificate of sterilization should be. It's very important. You have to issue it 1 month after the surgery or after the next menstrual period by the medical officer of the facility. If the client does not have her periods even after 1 month of surgery, rule of pregnancy before issuing the sterilization certificate. Now coming to failure rate, it is less than 1 pregnancy per 100 women years in the first year. And if you take the cumulative rate over 10 years, it is 2 per 100 women years, or say 18 to 19 per 1,000 women. Increased failure rate with concurrent and peripheral sterilization, as I already mentioned. And deaths very rare, 1 in 13,000 to 1 in lakh, more so with regional and general anesthesia than local anesthesia. So people doing in camps are much safer than one doing in the institution. Now, this is very, very important. The family planning indemnity schemes. The section 1 is for the beneficiaries, and section 2 is for the empaneled doctors and health facilities. So first is death following sterilization operation, inclusive of on the table death or in the hospital or within 7 days from the date of discharge from the hospital will be 2 lakhs. First, then 1B is death following sterilization within 8 to 30 days from the date of discharge from the hospital would be 50,000. And failure of sterilization, it is 30,000. And 1D is cost of treatment in a hospital and up to 60 days arising out of complication following sterilization operation, say for example, surgical site infection or whatever. It would be actual cost not exceeding rupees 25,000. So this should be told to the patient because they should not claim higher charges later on, okay, if there is any complications. Then section 2 is for the empaneled doctors under public and accredited private NGO sector and health facilities under public and accredited private NGO sector 2. Then indemnity coverage is up to 4 cases of litigation per doctor and per health facility in a year, up to 2 lakhs per case that is performed, okay. Then who can claim? Site. Recognized and the site which is recognized and has not charged for the procedure from the client. Doctor who is empaneled and training certificate holder. So you can imagine, understand why training is important, and you should be empaneled also to perform this sterilization. And client fulfills all the criteria of eligibility. And period claim process to be initiated within 90 days of the event by the beneficiary, and stipulated time limit for settlement of claims would be 15 working days in case of death and 21 days in case of others after submission of all required documents. So this is the to become eligible eligibility of the providers to perform sterilization procedure. For female sterilization, of course, all after doing your post-graduation, you can do mini lab, but both diploma and degree holders. But specialists from other surgical fields and MBBS doctors, they have to they have to undergo training in mini lab sterilization. And for laparoscopic sterilization, just do not think that just because you have completed your degree in obstetric and gynecology, you can perform laparoscopic sterilization. You have to get trained and get the certificate. So you have to undergo training. So other specialists from other fields also have to undergo, and MBBS doctors who are performing mini lab sterilization also should undergo they also can undergo this laparoscopic sterilization. For males, both conventional vasectomy and no scalpel vasectomy, we have to get trained for both the procedures. So, the training site should have more than 50 cases per month, and at least 2 trained providers should be there. And it should be state quality assessment committee and district quality assessment committee recognized. So each trainee must observe and assist at least 5 sterilization procedures and perform at least 5 independently to be certified as service provider for that method. If the trainee is not still confident, he can go for a refresher course for a 3-day course. Then trained provider should not do cases in a camp beyond 5 p.m. and before 9 a.m. and never more than 30 cases per day. But it is never observed. Most of the camps, even I have performed up to 50 cases per day, which is wrong actually. Whether private surgeons can perform in sterilization operation. Trained providers from private hospital can be considered for empanelment if such institutions are accredited by the government. The quality assurance committee formed at state and district levels are empowered to empanel the providers. Once a provider has been empaneled and his facility has been accredited, they cannot charge anything extra from the client. And upon accreditation, they are bound by the compensation scheme and family planning indemnity scheme of the government of India. So this is the advantage. Surgery must be cashless to the clients and no fee can be charged even under the garb of providing medicines or disposables, etc. So that is the condition. Okay. So in the private hospital, the accreditation requirement should be at least 1 empaneled gynecologist or surgeon or whatever MBBS who is holding the certificate for mini lab or even LTO should be available. 1 OT staff nurse or LHV or ANM, 1 OT assistant, anesthetist if required, and laboratory technician. For male sterilization, of course, the trained doctors and the same other things are same. Coming to vasectomy, the first, again, a little bit of history. The first recorded vasectomy was performed on a dog by Cooper in 1823, and it was the first human vasectomy was done in London by Harrison. The first vasectomy program on a national scale was launched in India in 1954. NSV was developed and first performed in China, and Dr. Kaza and Dr. Alok Banerjee in India, they performed the first NSV in 1991. So again, are there any contraindications or the prerequisite for this vasectomy would be man should be above 22 and below 60, unlike the woman. Any trained and empaneled doctor can do the surgery. Consent is mandatory. Spousal consent is not a requirement. Explain that the failure rate is very low, 1 in 2,000, and immediately not effective. So this should be told to the man and properly counseled. And certification is done only after semen analysis, after finding out that there is azoospermia, which may happen after 3 months, and additional need for contraception till then. So are there any contraindications? The medical eligibility criteria is same as for female sterilization operation, that is accept and cautious delay or special situations. So these are various technique, ligature, clips, thermal or electrocautery, chemical occlusion, plugs, vas excision, the commonly used one, open-ended vas, facial interposition, vas irrigation, some of the pictures showing that. So this is the no scalpel vasectomy. I see it is no scalpel vasectomy, so scalpel is not used. So incision is just through a small puncture is done with using a special instrument. Only one small puncture here, and you identify the vas, occlude, cut a ligament, cut a segment, and ligate the cut ends. No suturing is required routinely. So this is the picture showing just local infiltration and removing the with one puncture. Both the vas can be tackled, and this is the dissecting process, very important, where you dissect after puncturing, and then these are ring forceps to hold the vasectomy. Sorry, vasectomy certificate should not be issued to the client unless the semen analysis is done after 3 months and azoospermia is confirmed. And if the report does not reflect azoospermia, even after 6 months of sterilization, the sterilization certificate should not be issued to the clients. Such cases where a certificate of successful sterilization has not been issued are not eligible for compensation under the failure of sterilization clause of the family planning indemnity scheme. So these are some of the advances: subcutaneous vas occlusion or RASUG, hysteroscopic sterilization, Assure. I don't know, like not very popular. I don't know whether in the Western countries they are still using Assure. The devices are placed through hysteroscope and chemical methods, that is tubal occlusion by using quinacrine pellets, which can cause fibrosis. That is also not very popular now. And a word about reversible inhibition under inhibition of the sperms under guidance. This is an indigenous method developed within our own country. It's a non-hormonal injectable contraceptive. It is, as the name suggests, it is reversible, where stearin malate and hydrate is mixed with the solvent and it is injected. It blocks the vas and destroys the sperms. And reversal is possible. There is a further development of this RASUG. It is called as the smart RASUG, where iron oxide and copper particles are added to the original compound, giving it magnetic properties, and the name smart RASUG. So the advantage of this smart is the polymer location can be extremely controlled with magnetic field, and polymer can change the location inside the body to maximize the sterility, or can be removed to restore fertility. That is the advantage of this smart. So impact of RASUG, so this is a picture of a couple, who has was one of the volunteers who has received RASUG in 1992, still having effective contraception today. And this RASUG is in extended phase 3 trial awaiting DCGI approval. Hope it will come into the market sooner. And these are some of my references. Thank you for listening to me. Once again, I thank Dr. Shobha and ICOG team for giving me this opportunity. Thank you.
Thank you so much. Thank you so much, Dr. Malini, ma'am. I think we don't have any questions.
No questions,
No,
because
no
they are doing, yeah, sorry.
So, thank you so much for the crisp and elaborate talk, ma'am. Is Dr. Padmaja here? I can see she's joined in.
Yes,
She's
yes,
logged in.
yes.
Yes.
Yeah.
So thank you so much, Malini, ma'am. Moving on to our next speaker. I would like to invite our next speaker, Dr. P. Padmaja, ma'am. Can I have a CV, please? She's a senior consultant and HOD at Government Hospital, Doda Balapur. She's a postgraduate teacher and has received Distinguished and NBE Teacher Award by ANBA in 2019. And she's member of BSOGS CME Committee and Chairperson Poster Committee ASOG 2019. Welcome, ma'am.
Yeah. Shall I share the screen?
Yes, yes, ma'am.
Can you see?
Yes, ma'am.
Oh, okay. So thank you, ICOG team and Dr. Shobha Gudi for the invitation to be included in this program. Sorry for the technical issues earlier, I couldn't join. Are you able to see the slides?
Yes, ma'am. Kindly put it on slideshow, ma'am.
Yeah. Is it okay now?
Yes, ma'am.
Yeah. So I'll be talking about natural family planning methods and barrier methods. I think some postgraduates are there in this group. So this topic is important for two reasons, I will say. One is for the exams, because definitely in the exams, you will get it either as a theory question or in the practicals, you may be asked about the natural family planning methods and barrier methods. And secondly, so if some patient comes and says, I don't want any other method, I want to go for natural methods or barrier methods, I see many of my postgraduates saying that no, the failure rate is high, don't go for it, you go for a copper tea. Then the patient may say, no, I don't want a copper tea or oral pills, and they may not use anything at all. So any method is better than no method. So that way, so we should be able to tell the patient what is the correct way of using any method, so that if they want this method, it's a cafeteria approach. So if they want this method, we should be able to explain to them what is the correct way of using, so that they'll use some method at least, instead of saying that, no, this is not a good method. Okay, I won't go into too many details about this. All of you know contraception, it's a limiting method or spacing method. And chance of pregnancy after one act of sexual intercourse is 3 to 4.5%. And our aim should be no pregnancy should be unplanned. All pregnancies should be planned pregnancies. That should be our aim. And barrier and chemical contraceptives, they have become important because of their public health impact, which I'll be talking shortly about. So these are the features of an ideal contraceptive. It should be reversible, inexpensive, self-administered, and simple to use, and offers STI prevention. These are some of the features, and natural and barrier contraceptives, they fit into many of these features. And the goal of modern family planning is provision of effective contraception, maximizing the non-contraceptive benefits, lifestyle advantages. So it has some role to play. So before we say, no, it's not a method. Okay, according to the CDC 2014, STI and HIV testing is included as part of the family planning care now. So STI prevention is part of family planning care. Earlier, the dermatologists and the DVD departments, they used to take care of it, but now it is included. STI prevention is part of the family planning care. So now if we come to the efficacy, I won't go into the details of what is the efficacy of a contraceptive method. Okay, so if you look at the effectiveness of the contraceptives, the barrier methods come a step above the natural methods and spermicide methods. So of course, the efficacy is much less compared to the other methods, but still, as I said, they do have a role, and we should be able to maximize the efficacy by correct usage. So the natural family planning methods, there are 3 methods: periodic abstinence, lactation amenorrhea method, and withdrawal method. So let us see one by one. So the periodic abstinence, it's a method which is based on the physiological changes in the woman's body, the physiological changes, so that we will identify the fertile phase. The same thing earlier we used to do for infertility treatment also. We used to identify the fertile phase and tell the patient this is the time when you should have intercourse. Whereas in contraception, we identify the fertile phase and tell them that they should not have intercourse during the fertile phase. There are different methods in this: calendar method, cervical mucus method, basal body temperature, and other methods. So what about the calendar method? In this doesn't work if the woman is having very, very irregular cycles. Suppose she has sort of regular cycles, then we have to record the length of the last 6 cycles. Okay, and so we calculate the fertile period. By the beginning of the fertile period will be the shortest cycle minus 18 days, and the end of the fertile period will be longest cycle minus 11 days. So that will give us the fertile window from which day to which day. So we tell the women that they should not have intercourse during this period. This is the calendar method. And but for the calendar method, you need to have the 6 months record of her cycle's length. What is the length of the cycle in the last 6 months? Whereas cervical mucus method, all of us know, and even all the patients also know their body if you explain to them. Okay, because this is also called the Billings method. Here we observe the changes in the cervical mucus over time due to estrogen. Because of the estrogen, the cervical mucus, the quality changes with the menstrual cycle. Immediately after the menstrual cycle, the discharge is quite thick. Whereas in the middle of the cycle, it becomes copious, very thin, translucent. Even the woman knows that these changes that are happening in her body. And also towards the menstruation, again, it becomes more thick. So we can tell the patient to observe the mucus, and whenever the mucus is thin and then copious, then that is the fertile period. She can avoid that. Whenever the mucus is thick, she can have intercourse. Okay, and of course, basal body temperature. Earlier, as part of infertility workup, we all used to do the basal body temperature. Here, the basal body temperature is recorded early in the morning before they get out of the bed. And prior to ovulation, the temperature usually falls about half a degree below the normal. And just immediately after ovulation, it raises again 0.2 to 0.4 degrees above the basal level. Okay, this variation we observe. So we ask the patient to record her temperature. Whenever there is a dip, from that day till 3 days after the rise, she should, that is a fertile period which she should avoid. Okay, so this is the basal body temperature. Immediately around the time of ovulation, slowly the temperature falls. It may not be much, but if they have a graph which is recorded, they'll be able to observe. Okay, there will be fall followed by slight rise. So after the rise, immediately after the rise, the fertile period will not be over, will take 3 days. So we should tell her from the time of the fall till 3 days after the rise, that is a fertile period which she should avoid. This is the basal body temperature. So there is another method called symptodermal method. We can combine both. We can combine basal body temperature as well as the cervical mucus method. So as soon as the cervical mucus becomes thin, and then plenty of mucus is there, she can start checking her temperature. And once the temperature rises, about 3 days from the time of rise, she can avoid. So this here we are combining both the methods. So essentially, this is like we should have good knowledge about her physiology. And this is again standardized method. Some of the government hospitals, they still follow this because this is essentially for illiterate patient. Hopefully, we will not have so many illiterate patients. But suppose she is really village patient who cannot even mark on the calendar. Okay, then we can tell her about this beads method. This is a beads method. Okay, you have colored beads and there is a sticker on that. So she can keep changing the sticker to the bead as the day progresses. And then like we can tell her, all the white beads she should avoid. Sorry. So if you can see, there is the sort of one sticker is there. This she can keep. This is the red bead is the day she starts her cycle. Okay, this ring she can keep changing with each day. And all the white beads she should avoid intercourse, and colored bead she can have intercourse. Okay, this is how you can explain to a really illiterate patient. If you go to North India, many hospitals, I mean, you do see, like even in South also, you still have patients who may not understand all this calendar method and all that. So this is quite easy and she has control on that. She can calculate herself and then do. So in the exam, sometimes they do ask this method, this beads method. Okay. So what are the advantages of these methods? Like, there are no side effects as such. They're quite economical and they don't interfere with her natural fertility, no health risks involved. But the disadvantages are they have high failure rate, but there is no protection against STIs. And sometimes they may cause mental strain for the couple. So if somebody wants to follow natural methods, you explain to them properly what is the correct way of following. Now coming to the lactational amenorrhea method, here a lot of confusion is there. Even our ASHA workers are also very confused as to what exactly is LAM method. Okay, this is the method for till 6 months postpartum who are exclusively breastfeeding. This is very, very important. See, many of the women, they may be giving half feeds. Sometimes they may wean the child and they may be giving top feeds in the daytime and only night they may be feeding the baby. So this will work up to 6 months postpartum if they're giving exclusive breastfeeding. Exclusive breastfeeding means all feeds, including the night feeds, should be from the breast milk. So essentially the mechanism is the lactation will elevate the levels of prolactin, which will cause positive feedback and dopamine. And then that will inhibit the pulsatile release of GnRH, leading to anovulation. This is the physiology. So we are using that. So this works for 6 months postpartum if she is exclusively breastfeeding. But we should remember, after 6 months, she may start ovulating even if she has not resumed her cycles. So beyond 6 months, this method really doesn't work. So the advantages of this method is like all the advantages of breastfeeding are there. Better mother-child bonding, it's quite economical, no side effects as such. But beyond 6 months, she should not continue this because ovulation may resume beyond 6 months. And if she's not, if she is partially feeding the baby, then the benefit is not there and there is no protection against STIs. Now coming to withdrawal method, this is also called coitus interruptus. Here the semen is discharged outside the female vagina during the sexual intercourse. The penis is withdrawn just before the ejaculation. The advantages are this doesn't require any medical supervision, it's free of cost, no health risks are involved. But the disadvantages are like accidental deposition of semen in the vagina, high failure rate is there, and it also requires great motivation from the partner. So now coming to, so these are all the natural methods. In case patient comes asking that they want to follow natural methods, please explain the correct method of using. Now coming to the barrier methods. Barrier methods, like I said, they have a lot of public health impact also. They're very, very important. I think we should bring back the barrier methods in a lot more ways. Okay, so as you see, most of the methods are, all the methods are all female dependent, whereas the male condom is the only one which is for the males. But I mean, this is the most popular. So the barrier methods, why do we think the effectiveness is less? No, the effectiveness varies. Actually, the effectiveness is, the failure rate is between 2 to 32%. It's a large variation. Okay, if they use correctly, it is successful. I mean, the failure rate is only 2%. If it is not used properly, then the failure rate can be up to 32%. So as you see, it's very, very important. They should know the correct method of using. Okay, so the effectiveness depends on the, it is all are female dependent except the male condom. Okay, it is associated with sexual behavior of the person. So all these affect the effectiveness. Okay, it needs a lot of motivation, especially from the male partner. Okay, most of the time what we observe is the lady wants to follow contraception. She's tired of pregnancy. She wants to go for contraception, but her husband may not listen to it. So then it results in failure. Okay, so perfect use is associated with less failure rate. So it's very important to explain the perfect usage. So what are the indications for barrier contraception? Where other contraceptions are contraindicated. Suppose she has some medical issues, so she can't go for pills or IUCD. Okay, then this is a good method to use. And those who want a reversible method without, some patients don't want to go for pills or a IUCD. For them also you can advise. And like suppose the husband, like there is an interim method. You want to go for a copper T insertion for the lady, but she want to take some time. She want to go after her next cycle. So this cycle, let her use barrier contraception. So as an interim method, you can advise. And during lactation and puerperium, as an adjunct to LAM method, you can advise barrier contraception. And suppose the husband is staying somewhere else and he comes once in a month or once in 3 months he comes. So infrequent episodes of contact, you can advise. And also if they're all those who are at risk of STIs, so you can advise as a dual method. In fact, what I will tell my patients is, even if the woman is using some other method of contraception, even if she had undergone tubectomy, even then you should encourage the husband to go for barrier method, because this has dual protection. It protects against STIs as well as it gives contraceptive benefits. So even if not for STIs, even if not for contraception, they should at least use it for STI prevention. So everybody who comes, advise them about barrier contraception. Even if they use few times, it is worth it because it prevents STIs. So like this male condom has been there for many, many years, actually from 16th century. Initially, they were more clever than us. They initially discovered it to prevent syphilis, to prevent STIs. Okay, and then it came, they also found that it has a contraceptive benefit also. Okay, the condoms, most of the condoms are made of latex. You also get polyurethane, silicone rubber, and some natural membrane contraceptions condoms are also available. These are all male condoms. Okay, the natural membrane is from the lamb cecum, it is made, but it doesn't prevent against STIs. It can have contraceptive benefit, but all others have benefit of both. So the male condom, the latex condom is, all of you should know all these. Sometimes in the Viva, they may ask, it is 0.3 to 0.8 mm thick, 15 to 20 centimeters long, 3 centimeters in diameter, and it is available free of cost in all the government hospitals. All of you know, Nirod is available in all the government hospitals. Nowadays, you have condom vending machines even in bus stands and railway stations also for those occasional users. So it is very useful, So, and polyurethane condoms are resistant to heat, but it is made of thinner material. So chances of breakage is there. So we usually advise patients to use latex condoms, but those with latex allergy can go for polyurethane condoms. The condoms have become cornerstone of family planning because of infection prevention also, like again and again I'm saying. Sorry. So the steps for maximum condom efficiency. So how do you advise the patient? It should be used at every act of coitus. So when they want contraception, you should tell them irrespective of fertile period, whether it is fertile period or not. Every time, every act of coitus, they should use the condom. And it should be placed before making the vaginal contact. And a reservoir must be created at the tip. And when the penis is erect, it should be withdrawn. Okay, so it should be applied when the penis is erect, and it should be removed also when the penis is erect. That is the correct method of using. So the advantages of condom, like I said, it's hygienic, easy to carry and easy to dispose. It prevents sperm allergy. Rare cases of sperm allergy, it can be useful, and it is useful for couples having infrequent coitus, and relatively inexpensive. It does not adversely affect the pregnancy in case there is a failure rate. It does not interfere with the menstruation. And there are many condoms which are coming with spermicides and lubricants and all that. But some studies have done to find if there is any extra efficiency, but the efficacy is not increased because of these lubricants. It's not used. So the perfect use will lead to only 2% failure rate. And what are the non-contraceptive benefits? So it prevents sexually transmitted infections, including HIV. Okay, infections by consistent use, infections and HIV can be reduced by 70%. It prevents PID, prevents tubal infertility, and it also benefits for prevention of CS cervix. Very, very important. HPV infection is prevented, so it is beneficial as CS for prevention of CS cervix also. So my advice will be, you should tell everybody, irrespective whether the woman has undergone sterilization, whether they're using any other method, even after she has a copper T, they should go for barrier contraception, male condom. Okay, and also some cases of immunological infertility also, condom is useful. But the disadvantages, rarely there can be latex allergy, risk of breakage and slippage and leakage of serum can be there, and it has to be used with every act of coitus. They can't intermittently use, and it is not reusable. And some people say it hampers the sexual pressure, but that I think once they get used to it, it may not be so much of a disadvantage. So what about the female condom? Female condom, it is made of polyurethane. It lines the vagina. It is hypoallergic and stronger. It completely lines the vagina. And if you can see, it has two rings. One inner ring with a closed end. Okay, this is a closed pouch, the inner end. And this is an open end. This open end lies over the vaginal introitus. This inner end, which is a closed pouch, it covers the cervix, so that there is no contact between the semen and the cervix. Okay, so this is the female condom. Okay, there are two brands. It is very much available in India. Two brands, which are FemShield and Femidon, are available. Okay, it can be removed by traction on the outer ring. You catch hold of the outer ring and pull it out, it will come out. This is the female condom. Okay, it can be worn up to 8 hours prior to the coitus, and it's not necessary that immediately it has to be removed. It can be there up to 6 hours. So later also she can remove it, and it also prevents genital ulcer disease. It is very useful, and failure rate is 5 to 21%. Even here also, I would say, based on the usage. So now coming to diaphragm. I don't know if any of you have seen the diaphragm. Diaphragm is also available in India. Okay, this is also a very old method. In fact, this was a very popular method before the IUCDs and oral contraceptives were developed. It was very popular in 20th century. And it is the first effective contraceptive methods which is under women's control. So it was very, very popular at one point. Okay, there are many types of lattice diaphragms, and it is a reusable. Female condom is not reusable. It is one-time use and throw, whereas a diaphragm is reusable. They can wash it and use it many times. Okay, the success of a diaphragm depends on the proper fitting. Okay, so they have to go to this requires medical supervision. The first time they have to go to a doctor, and we have to measure what is the correct fit of the diaphragm for the lady. The proper fit is very, very important. So how do you know which is the correct size? Is exactly like how you measure the diagonal conjugate. In obstetrics, you will be measuring the diagonal conjugate, keeping 2 fingers in the posterior fornix, and then you measure the distance up to the symphysis pubis, like how you measure diagonal conjugate. Okay, you measure that is the correct size of the diaphragm, the diameter of the diaphragm. So this, see, with the childbirth and repeated sexual intercourse, the vagina may become lax. Okay, so every year the diaphragm measurement should be taken, and you should see the correct fit of the diaphragm. That is the only disadvantage with this, because they have to go to the doctor every year. It has to be seen. So once they find the correct fit, it fits inside and it can be removed after 6 to 8 hours. Okay, only thing is they should not forget to remove it. So it cannot be left inside for more than 24 hours. This is the correct fit. Okay, so you measure the diagonal conjugate from the posterior fornix to the lower end of the symphysis pubis. That gives the correct fit of the diaphragm, and it just sits in the vagina like a pessary, essentially. Like pessary, many of you must have seen. Like essentially like a pessary, it sits, but it is covered underneath. Okay, so it totally covers, it sits inside, and after using, it can be removed, washed with soap and water, and it can be reused. Okay, but only thing is, whenever there are a lot of changes in the weight, either weight gain, weight loss, or repeated vaginal deliveries, the vaginal caliber can change. So the fit of the diaphragm should be assessed every year. Okay, so if it is correctly used, the failure rate is only 6%, otherwise it is 16%. This is about the diaphragm. Cervical caps, of course, cervical caps are, I think diaphragm and female condom, the efficacy is much better than cervical cap. Cervical cap comes much lower in the efficacy wise. Okay, this is just a cervical cap which just fits into the, as you can see, it just fits into the cervix, and it just stays there just for the cervix. It doesn't line the vagina. Okay, so those with too long cervix or too short cervix cannot use it. And those, like, suppose a woman is using diaphragm and the vagina has become too lax, she can't find the correct fit of diaphragm, then maybe she can go for a cervical cap. Okay, so these cervical caps, it's made of, again, silicone rubber. Okay, 3 sizes are, there are different types of cervical caps which are available. Some with a handle like this, they can hold with the handle and then remove it. For removal, it's quite easy. So many types are there, many types of cervical caps. I don't think cervical caps as of now they're available in India. I'm not very sure, but diaphragms and female condoms are very much available. So cervical cap cannot be used in cases of unhealthy cervix, very short cervix, any growth on the cervix, okay, and any lacerated, inflamed and infected cervix, it cannot be used. And even in the postpartum period also, we don't advise it up to 6 weeks postpartum, or even a mid-trimester abortions also for 6 weeks, we don't advise it. But diaphragm can be used in all these cases. Okay, coming to contraceptive sponges, I showed you at the beginning, the efficacy of contraceptive sponges is much lower than the barrier contraceptives, and they have sustained release system for the spermicide. This contraceptive sponge, it constantly releases the spermicides, and it also absorbs the semen and blocks the entry of the entrance of the cervical canal. Okay, there are many which are available in the market called today's sponge, protected. Okay, essentially they have a chemical, impregnated chemical, okay, which act as a spermicide. So there are some Cochrane reviews on sponges, and they found they're less effective than diaphragm in prevention of pregnancy, and also it may cause vaginal dryness, so constantly it may not be advised. And once in a while, if they want to use, they can use it, but not as a regular contraceptive. Regular contraceptives, other methods are better. Okay, there are some spermicidal gels are available, spermicidal creams are available. Okay, all these, many women find it's very convenient. They can just buy it and then use just at the time of intercourse. They can use. All of them have this. This is a whole list of chemicals which are there in all these. Okay, most common is anoxinol 9. This is the one which is there in all the spermicidal foams, jellies, creams. Okay, and even there are some with betadine also. So essentially our aim is whatever method is available, let them use something, okay, instead of not using any method at all. So the advantages of these methods, these spermicides, is it's easy to use, and it provides some protection against STIs because it is acting as a spermicide. It has a chemical, some protection is there. Okay, antiviral properties of nanoxynol 9, it has to be studied. It is not proven yet. It may protect against cervical cancer, but the disadvantages for some people, it may cause local irritation, high failure rate is there, and there is increased risk of HIV if there are genital lesions. Okay, and it has to be repeated with each act of coitus. So this is some comparison as to how long this can be kept inside, and after coitus for how long. The diaphragm and then female condom up to 6 to 8 hours before the coitus, it can be inserted, and it has to be removed about 6 hours later. So maximum wear time is 24 hours for the diaphragm as well as female condom is, we ask them to remove it once in, like after 8 hours. It should not be left inside. Okay, so what is the future? Future is, I will tell you, I will say it's about dual protection. So again and again, I'm insisting on that. Please ask the patients to go for barrier contraception, irrespective of whether they're using other method of contraception or not. You tell them this has other benefits also. So I think that point we should put it across. So we should help in increasing the usage of barrier contraceptive. Okay, because it prevents against STIs, HIV, and even most important is it helps in prevention of CA cervix also. And focus should be on research and development of maybe new microbiocides should be developed to act as chemical contraceptives for the future. Okay, so thank you and I once again thank Dr. Shobha Gudi and ICOG team. Sorry for the technical issues, but I hope you have any doubts or any comments on this?
Presentation, Padmaja. Thank you so much for coming and joining. It is okay. We were able to manage with Dr. Malini. It is fine. Thank you so much.
Thank you. Yeah.
Thank you so much, ma'am. So moving on to the last interactive session, I would like to invite Dr. Radhika. Can I
hello.
have a CV, please?
Yeah.
Hi.
Good afternoon, everyone.
So Dr. Radhika is assistant professor at Bangalore Medical College, and she's a master trainer for PPIUCD, CAC, DMPA, SBA projects. Welcome, Dr. Radhika.
Yeah, thank you. Okay, I want to share the slides. Just a minute. Are the slides visible?
Yes.
Yes.
Okay, so we are moving ahead with the case scenario, and it's sort of a quiz. I request all the participants to please post their answers in the chat box so that I'll give the answer later. Okay. So the first quiz question is, following IUCD insertion, what instruction should not be given to the client? She should be told to come back to the health facility soon if there is any problem or concern. She should feel the threads with her fingers after each menstrual period. Sometimes there can be increased bleeding and cramps in the lower abdomen during the first 2 to 3 months of insertion. None of the above. I request postgraduate students to Okay. So I think only one person has posted the chat. Okay. Yeah. Okay. So the answer is actually the instruction which should not be given to the patient is that she should feel the threads with her fingers after each menstrual period. So this guideline is actually by the World Health Organization, both by WHO and by NHM Government of India. So once we insert the IUCD, don't tell the patients to keep on feeling for the threads after every menses. Earlier in the olden days, this was advice we would give for many women, mainly because ultrasound was not easily available. And whenever women try to feel the threads, actually there may be some displacement or expulsion of the IUCD, which may be more. So that is the reason NHM, Government of India and WHO both have recommended against the feeling of threads with the her own fingers. Okay. Yeah, but this guideline is still remaining in the UK guideline. In the abroad guideline, it is still there. But as per the Government of India and WHO, the woman should not be asked to feel the threads every cycle. So that is the one question. If the IUCD is tarnished, that is if the color has changed, but the IUCD is still inside the intact and an undamaged packet, which of the following action is correct? If the expiry date on the packet is still not passed, one can insert the IUCD, send the packet back to the manufacturing company, do not use the IUCD as it might harm the woman, report the incident to the district officials. So the IUCD has become blackish in color. So should it be used, or should we send it back to the manufacturing company and it may cause damage to the person? So which of this is actually correct? Okay. I don't know why only one person is participating. All the others, I'm not getting any answers. All the postgraduate students who are sleeping, please get up. Okay, we'll move on to the answer. Okay, so if the expiry date on the packet has not been passed, we can still go ahead and use the IUCD. Tarnishing or the change in the color will not affect the efficacy of the IUCD. As long as it is in the intact packet, that is the package is sterile, you're sure that the package is actually intact and it is not damaged, the packet is not open from anywhere. In that case, even if the IUCD is tarnished, it can still be used. Okay, so as I mentioned, all the questions and answers have taken from the NHM Government of India guidelines. Okay, so this IUCD can still be used. It will not cause any harm to the women. It will not affect the efficacy also. So what is the risk of perforation at IUCD insertion? 0.5 to 1 per 10,000, 0.6 to 1.6 per 1,000, 10 to 16 per 1,000, 1 to 1.6 per 100. So just a rough figure so that it will help us in counseling the women. Okay, approximate what is the risk of perforation at IUCD? Okay, so the risk of perforation is around approximately 1 per 1,000. So that is the one which is used for counseling. It is usually 0.6 to 1.6 per 1,000. That is the risk of perforation. It is very less even with the post-placental. In post-placental, it may be even approximately 1 in 10,000. But generally, the risk of perforation of IUCD is 1 per 1,000. 30-year-old woman wants to get LNG IUS inserted. She wants to know at what time of the menstrual cycle it can be inserted so that she doesn't need additional backup. So we know that at the best ideal period will be there. After that, we'll ask the woman to use a backup. So which is that ideal period? So insertion should be within 7 days. Insertion should be within 5 days of LMP or within 9 days of LMP, or it can be done anytime during the menstrual cycle without any backup. What is the answer? Dr. Nikila, you can continue to participate. And thanks for the answers, for active participation.
Yeah, I think at least one candidate is there who is interested. She has told us B.
Yes. Yes, ma'am. So all the methods of contraception, ideally all hormonal method of contraception, injectables, everything actually is usually prescribed within 7 days of LMP. That is the ideal time of using starting contraceptive method. If you are using more than 7 days, in those women actually backup method is required. Okay. The one thing which has to be remembered is copper IUCD is the one where you don't need backup because it also acts as an emergency contraception. Okay, so copper IUCD can be inserted anytime during the cycle, provided there is no previous history of unprotected sexual intercourse. In that case, it can be inserted even after 7 days of LMP without any backup. For LNG, we can, if it is inserted more than 7 days, backup is required for 7 days. Again, all the hormonal methods, whenever it is inserted, then it has more than 7 days. For combined hormonal contraceptive pills, because it's a low dose pills what we are using nowadays, if it is more than 5th day of menses, then we have to give a backup of 7 days. Okay. Earlier with the conventional combined hormonal contraceptive pill, where the dose was more than 35 microgram, that time it could have been up to 7 days. But now if it is more than, whenever it is started more than 5 days of menses, backup is required for at least 7 days. For progesterone only pill, okay, because the local action, the thickening of the cervical mucus is very important in this method, progesterone only pill. So backup is required for only for 2 days. Okay, so this is the information. Okay, thank you. Patient had given one more next question. Patient has given consent for LSCS with postpartum IUCD insertion, but doctor has closed the abdomen and he or she forgot to insert the PP-IUCD. What is the next option available now? Okay, so PP-IUCD can be inserted vaginally immediately after LSCS. PP-IUCD can be inserted vaginally within 48 hours of cesarean section. Provide any other contraceptive method and can follow be done at 6 weeks for IUCD insertion. Any of the above. Last option is any of the above. Yes. So yes, you are right. So the answer is actually it cannot, once you have done the cesarean section, the same rule of within 48 hours of PP-IUCD is not applicable for cesarean IUCD insertion. So we have to provide other contraceptive method, and we should ask the lady to come back at 6 weeks for IUCD insertion. Okay, so which is not a contraindication for PP-IUCD insertion. So we know that there are certain contraindications for postpartum IUCD, which is not a contraindication. 12 hours of PROM, 18 hours of rupture of membranes to the delivery of the baby, unresolved atonic PPH, extensive genital trauma. So which is the one which is contraindication for, which is not a contraindication, sorry, which is not a contraindication for PP-IUCD. Okay, so here the option has to be from either between 1 to 2, because both 1 and 2 cannot be correct. More than 12 hours of PROM and more than 18 hours. So I'm asking which is not a contraindication. So even extensive genital trauma also we don't usually use it. So more than 12 hours you can still go ahead and insert. 18 hours and above is a contraindication for insertion of PP-IUCD. Okay, so how many ejaculations does it generally take for a man's vas tubes, the tubes that carry sperm from the testis to the penis, to be free of sperm after a vasectomy? I think Mali madam clearly mentioned this in her slides actually. So answers options are up to 8, but only a semen test can tell for sure. Up to 16, but only a semen test can tell for sure. up to 24, but only a semen test can tell for sure. Or it is not the number of ejaculations, it's a time, that is 2 to 3 months, rather than the number of ejaculations which is critical. So what is the right answer? So after vasectomy, generally when do you say that it is actually sterility is assured? Okay, I request others to participate. Okay, so the answer is actually, it will usually take up to 16, but again, only a semen test can tell for sure. Okay, so that is important. And this one also, like once you have done it, when do we give sterilization certificate? After no scalpel vasectomy. So madam mentioned after tubectomy, usually we give sterilization certificate after 1 month. It is not immediately. We don't give the certificate immediately after the surgery. We usually give it after 1 month as per the Government of India recommendation. Okay. For men, for after no scalpel vasectomy, when do you issue a sterilization certificate? After 6 months, at 3 months, immediately after surgery, at discharge. Okay, at 3 months, yes. Okay, so usually it is done after 3 months of vasectomy, you are going to issue the sterilization certificate, and definitely after doing a semen analysis. Yes. Yeah. Thank you, Nikila. So I want you to give the answer true or false. You can type it as TRF. Okay. So LARC is the one method which requires administration of the method less than once in every 3 months. Is it correct or false? What is the definition of LARC? By definition, what is LARC? It is false. Okay. So LARC is the one where it is actually the administration requires less than once in a month, in 1 month. Yes, it is not once in 3 months. It is less than once in 1 month. Correct answer. So using a smaller amount of 2% lignocaine solution will provide better anesthesia than a larger volume of 1%. Is it true or false? If you're using local anesthesia for doing tubectomy or no scalpel vasectomy, so usually what we will be using is actually, it is 1% xylocaine, not the 2% xylocaine. Okay, so it is actually a false sentence. Okay, so we'll be using actually larger volume of 1% xylocaine, so that you will be able to give local anesthesia both skin and up to the peritoneum, so that you will be able to give a larger volume. If you cannot use exceeded, generally the maximum dose what we use is actually 20 ml of 1% xylocaine, not more than. Sorry, ma'am. You're able to hear me, ma'am?
Yeah, I'm able to hear you. Yeah.
Ma'am, should I continue with the next set of quiz, or
How
what do
many
I
did
do?
you do? Did you do at least 10?
We did 10, ma'am. Yes, ma'am. We did 10.
I think it should suffice for today. I
Okay, ma'am.
think it should suffice
yes.
for today. So I'm so very grateful that the faculty who joined have been here till the end, and also the postgraduates, whoever could join. So definitely we have to rethink about our strategy for continuing this program. So now if anybody wants to give a comment, if Dr. Lakshmi is there, if she wants to say anything. Otherwise, I'll request Riju to give the vote of thanks, or any of the participants. Do you have any input to give? Yeah.
Dr. Pratik, sir. Yeah.
So very nice talks and very well thought out slides from all the participants. I must commend all the creators of these slide presentations for the thought process, especially the multiple choice questions. I think these are some things which we usually don't incorporate in standard slide presentation, and this is of interest to postgraduate students. I hope more and more of the intended participants will take benefit from these presentations. We will, of course, record all of these talks and we will put them up on the ICOG website. Congratulations, Dr. Shobhagudi, for putting together a well thought out program over 2 days. And again, thank you to Dr. Lakshmi Srikhande for permitting us to conduct this event, Sankalp event, on the ICOG platform.
Thank you so much, Pratik. Thanks a lot for the support you have given. Thanks a lot.
Thank you so much, sir. At the outset, I would like to thank Dr. Shobhagudi ma'am for making me a part of FOGSI ICOG Sankalp webinar. I thank Lakshmi Srikhande ma'am for I thank you, Lakshmi Srikhande ma'am, Chairperson ICOG. I would also like a feedback from all the students who have logged in, even though we had very few participants regarding the timing or whatever, because this we had wonderful 2 days webinar with excellent presentations with excellent faculty. So I would like a feedback. What more do you want with regarding the timings? Because it's for the PG students. So I thank all the speakers, Dr. Pratik Tambe sir, Dr. Padmaja ma'am, Dr. Malini ma'am, Dr. Radhika for excellent interactive session. Thank you so much, all the participants and all the medical colleges, all the HODs and the professors who have logged in today. Thank you so much.
Thank you. Thank you. We take leave at this point of time. Is Dr. Lakshmi there? Nilima?
I think Lakshmi ma'am is busy.
ठीक है. We will conclude then. Thank you so much.
Thank you.
And next time, all of you. Yeah, you can end.